All right, so it's my great pleasure to introduce Dr. Michaela Beater, who is a psychiatrist with the ACT team at St. Michael's Hospital and with Inner City Health Associates in Toronto. And she has been working for many years on advocacy, on improving the system for and providing care to people who experience severe mental illness, homelessness, substance use, criminalization, immigration-related difficulties, as well as refugee mental health. She's the Director of Mental Health and Substance Use Care for Inner City Health Associates and an assistant professor at the University of Toronto. She's also the Equity and Social Justice Lead for the Department of Psychiatry's General Residency Program and a community organizer working together with allies at Health Providers Against Poverty and the Healthcare for All Coalition and on issues of immigration detention. She was one of the original founders of Advocacy Day 10 years ago. And so it's great to be able to welcome her today.
Thank you so much. I'm really delighted to be here today. So I am going to be talking about health advocacy for health providers, specifically talking about access to healthcare for people who are uninsured. And I'm going to be talking us through a 7-step systems level advocacy framework. This is not the only way to do advocacy. I definitely don't always use this framework, but I do think it's helpful to sort of just organize my thinking in how a campaign can be designed. So today I'll talk about the framework, talk about some specific skills for a diversity of advocacy tactics. And I think this resonates very well with what Maggie was talking about, the different things that Health Providers Against Poverty has done and different tactics that have been used. And then I'll talk a little bit more specifically about access to healthcare for folks who are uninsured in Ontario. I always like to put this disclosure slide to say that there's no financial conflicts of interest, but I am a member of community and advocacy groups, including the Healthcare for All Coalition, Health Providers Against Poverty. And I think it's important to state that up front, to say this is actually part of my role as a psychiatrist. This is integral to the work that I do. So I wanted to just start us off by showing this slide from the Ontario Medical Association. This was from March 24th, so very recently, where the OMA put out this bulletin saying that the Physician and Hospital Services for Uninsured Persons program was going to be cut a week later. So this is a program that was brought in March 2020, which I'm sure everybody will always remember was the start of the pandemic, that we sort of really how it impacted us. And for the past 3 years, there had been a program that allowed for all hospital-based care to be covered for people who are uninsured, and also some OHIP codes that could be used in the community. So as soon as this news came out, there was a massive upswell of concern from within the health community and migrant rights organizations. And so this is just a tweet from a variety of photos from a demonstration that we did at Queen's Park. I'll talk a little bit more about that. But we also saw a lot of advocacy happening by health providers on Twitter, people emailing their departments, all of the different places that health providers were speaking up. So this is the 7-step advocacy framework, and I'll take us through all of the stages one by one. So the first thing is to consider an issue of relevance. So this could be really anything that you're passionate about, that you're thinking about. In my case, the issue that we were working on is that across Ontario, many people do not have access to OHIP covered care. Now, there are a lot of different groups who fall under this, and I think this is why it's particularly complex. So previously, we also had the 3-month wait. So if somebody had been outside of the country for a certain amount of time, like living somewhere else, they would have to wait 3 months before being able to get care when they came back. Or if somebody had PR, so permanent residency, they would have to wait 3 months. Now, I should say this has not been reinstated, so currently this is still suspended. Now, temporary foreign workers do have sometimes access to healthcare, but if they're between contracts, for example, they would not be covered. And I don't know if people have seen this in the news, but there have been lots of media coverage about the exploitation that happens when people come as temporary foreign workers. So these are the people who grow our food, a lot of people in the rural areas of Ontario, and people working in childcare and sort of various other places. Now, international students, if they are at a university, they will have something called UHIP, which the physicians in this group might be familiar with from having billed UHIP. But if you are from, sort of a smaller college that's not linked with UHIP, then often international students will not have coverage, or if they're sort of between courses of study. A large group of people is people who, might be filing a humanitarian and compassionate claim or have an inland sponsorship filed but not yet accepted. And then people who, are going to be filing refugee claims but have not filed them yet. And even when you file a refugee claim, there can be a bit of a wait sometimes before you have coverage. And then really the largest group is people who are non-status. So due to their lack of immigration status, they do not have access to care, are not eligible for OHIP. Now, during the pandemic, we also saw this program that was cut provide insurance to people who are OHIP insurable, but don't have a health card. And so this is actually a lot of the population that I work with on my ACT team. They might have a health card, but their version card is expired. And so I think it is really important to think of these as two individual groups, because one is OHIP insurable and the other isn't. Now, people have found ways to provide care for people who are uninsured in Ontario over the years, but none of these are as comprehensive as is needed. So community health centers play a really important role in providing care for people who are uninsured. They actually have a pot of money, and I know there's some colleagues here from community health centers who can probably speak to this in much more detail. But the pot is limited, and community health centers do not provide hospital level care, right? So they provide care in the community that is excellent and comprehensive, but they often have waiting lists and not everyone is able to get into a CHC. They're volunteer run and other walk-in style uninsured clinics that have opened up. So FCJ Refugee Center, the uninsured clinic, there's a whole variety in Toronto. But again, not sufficient and to meet the need, not available everywhere, and certainly not able to provide hospital level care. Midwives are able to provide low risk obstetrics care, but if somebody needs a C-section, for example, are not able to cover that. Public health clinics do provide coverage. Emergency rooms are a really interesting one because people are able to go to an emergency department and people are not supposed to be turned away. But there are many, many cases where people are asked for payment upfront. And if they don't have it, there have been cases where people are turned away from care. And I think people often are so afraid of going due to fear of, deportation, fear of debt, or fear of denial of care. And there's no way to access funds for cancer care, hospitalizations, home care, etc. So over many, many years, many organizations, groups, community organizations, health provider organizations have come together and advocated to call for access to healthcare for people who are uninsured. And these are just some of the groups. There are many more. So looking at step number 2 is, what can we learn about this issue? I've had to learn a lot in order to, understand the issue well enough to talk to decision makers, for example, to write about it and to do advocacy. So we can think about a gradient of precarity. So the most secure type of immigration status is if you have citizenship. Somewhat more precarious is permanent residency. And here I just want to say, for anybody who's working with somebody who is a permanent resident, but is eligible to become a citizen, it is really, really important, especially if that person is struggling with severe mental illness, substance use. If you can get your clients citizenship, support them through that process, that provides so much more security, because people with PR can still be deported if they run into certain types of legal trouble. Then there are folks who have temporary status, which is much less secure. And then you have people who are completely non-status, which is the most precarious. And I think it's really important to think about, to take a step back and think about the structures at play here. And this is a quote from a really phenomenal book by Harsha Walia, which says that classifications, such as migrant or refugee, do not represent unified social groups as much as they symbolize state-regulated relations of governance and difference. So these are human-created categories of people, the same way that borders are created by humans. There's nothing intrinsic about a border or intrinsic about a category of immigration status that somebody's in, and they can change as well. So looking at the national context, we know that precarious immigration status hurts families. This is an op-ed that was written last fall. There is a lot of work happening right now on a program of regularization by the federal government. And so there is hope that people will be able to gain immigration status, in this case, permanent residency, which would provide a lot more security. But what that program will look like is still under discussion at the federal level. And then there's been a lot of movement over the years by communities to call for really looking at the fundamental remedy for this, which is immigration status for people. Now, I think just very briefly, I wanted to also mention that the Roxham Road closure, which happened in March, I think is also a big part of, what impacts people's sense of precarity and fear when they are migrating. So going back to the directive, on March 20th, 2020, we received information from the ministry that they have requested that hospitals provide all medically necessary services to all persons who present at a hospital, regardless of whether the person presents a valid OHIP card or does not have health insurance under OHIP or another health insurance plan. And so this was, I think, one of the really important lessons for me, at least from the pandemic, which is that change can happen. When governments want to move very quickly, they can make this happen within hours, within days. And so I think we saw here a very, very rapid program be instituted. This was the info bulletin 4749, in case anyone wants to look like what that sort of the more fine-grained version of what this looked like for physicians. And this program, as I said, provided hospital-based care for people without OHIP, and also had 3 OHIP codes for community-based care that were optional for physicians to use, but which were used, I think, about $5 million a year. And so in March, we saw this program be cut very suddenly with 1 week notice. And so, looking at the next step is setting the agenda, right? And so what can the next step be in terms of engaging in this advocacy? So the initial objective was to stop the cut. Now, we were not successful in that, despite a lot of advocacy. And so the current goals are to call for a permanent program and to ensure ongoing access to care, both in community and hospital, for people who are uninsured. Now, in terms of the campaign target, I think I want to break that into 2 different ones. So there's the provincial government, that includes the Premier, that includes the Minister of Health. But I think also our hospitals, our workplaces, the places where we are active day to day at our community agencies in various healthcare settings. I think it's very important in both of those to think about how we can ensure that there's ongoing access to care. So what we did as a next step was gather our allies. And this was a really large group that, it's not even, the whole group here, but, we talked to students, health providers, hospital administrators, our professional organizations, so the OMA, various other health organizations, community organizations, people across Ontario. So very broad approach to see who our allies were. And I'll just take us back a little bit to August 2022, where we had actually, when we started hearing that this program might be in jeopardy. And so we did an open letter, and you can see here in terms of gathering our allies, all of these people here who have individual logos were joining us in really praising the government for having instituted this program and calling for its continuation. You can see that the letter was signed by people from all across Ontario. I think it's really important to say this is not a GTA specific issue, even though a lot of care, I think, does happen in Toronto, but this is an issue that people care all across the province. And here you can see this is sort of a specific tactic where we printed off our letter with all of the signatures and logos and brought it directly to Queen's Park. Now, the next thing is to design your approach. And I really believe in a diversity of tactics and knowing different tools and being able to use them in different places. So we started off with some community meetings to connect with allies. We did an open letter. We had discussions with various hospital the Ontario Hospital Association, MPPs, hospital administrators, organizational statements, demonstrations, direct action. I'll sort of take us through some of these in a little bit more detail. So I think research and publications are really key in, building an evidence base to show what is needed. So this is actually Angela Robertson, who sadly couldn't be here today, was one of the authors on this paper. And it looked at a large data set of emergency room visits by children and adults who are uninsured. And it showed that people were sicker when they came and more at risk of dying if they were uninsured. This is also another really helpful paper that outlined how immigration status is the foundational determinant of health for people without status in Canada, which is why the ultimate remedy is always seeing if we can get immigration status for our clients who are uninsured. The Health Network for Uninsured Clients wrote a report, which was really, really powerful and was shared a lot and got some media uptake as well. We saw lots of politicians and speaking up. In this case, this is Adel Shamji, who is an emergency room physician and who is with the Liberal Party and MPP. And so, there've been discussions over many years with various political parties highlighting the importance of this issue. Lots of power in lobbying our institutions. So our organizations represent us, right? Membership organizations, whether it's the Ontario Medical Association, the RNAO for nurses or other groups, they represent us and they need to take our feedback about what campaigns to work on. And so I think if there's something that you're interested in working on, thinking about how to involve your professional organization can be really powerful. Similar to what Maggie presented, we also did an op-ed. And I think that, it's really, really important to remember that as somebody who works directly with people in community, as somebody who's a health provider, you have valuable things to say. You have knowledge, you have experiences that can be crafted into a short narrative, either as a letter to the editor or as an op-ed. We did a social media campaign with a toolkit. We did a petition and letter writing campaign as well. And then there were a lot of organizational statements. So this was the emergency physicians, the Pediatric Society, the Ontario Medical Association, Medical Students, Alliance for Healthier Communities, which represents a lot of different organizations, the Ontario Psychiatric Association. And I think that, finding bodies who can speak out about this issue, similar to our Equity Council, which did as well. I think that can be very powerful, both as a knowledge building tool and also to send a message to decision makers and to the government. This is just the photo again from the demonstration we did, and here's a bigger picture. So taking the message directly to Queen's Park, to the decision makers. And then I think there's also creative actions that can be done. This was a intersection that we blocked close to the Ministry of Health to both create, to take the message again directly to the ministry and to really show how urgent this was, that we are willing to take a direct action to send that message. Here's the president of, former president now of the Ontario Medical Association, Rose Zacharias, who also did media. And I think we really saw the Ontario Medical Association speak up very strongly on this issue. And then the last step is really just to evaluate and reassess. And I think that that's sort of an iterative, process that happens ongoing. And so right now the recommendation is, to reinstate temporary funding, but also to work on creating a permanent mechanism for uninsured patients to receive healthcare, both in the community and in the hospital. And I think this program was such a success for patients and communities, obviously, but I think also for hospitals, because hospitals are often going to provide the care anyway to people, and finding a way to actually ensure compensation is very important. And then lastly, I think this is a very important program for physicians and health providers, because it allowed us to provide the care that we think people need from a medical perspective, and to be compensated for it. And so I'm just going to end on this as a last note, is what can we do as individual health providers? And I think this is both for people in the hospital system and in the community. And I think we can ensure that people have ongoing care. And this can happen in a lot of different ways. So we can advocate with billing departments for debt forgiveness. Sometimes people can be put on minimal payment plans. So it's like $5 or $10 a month. That is, it's still money for somebody who doesn't have a lot of money, but is more affordable than being faced with a bill for, $2,000, $10,000, $50,000. I think for those of us where it's an option, we can provide pro bono care or not charge people. The challenge is that within the hospital system, people will still get charged for the facility fees, which are often double what they are for Ontario residents. I think we can advocate for compassionate care policies to be created at our institution. So these can be discussions that everybody can have individually with your own hospital. I've had some of these discussions at Unity Health, where we approached various individuals and, did a presentation with one of the equity councils to say, this is a really important issue, and please can, this be at the top of the agenda. And then engaging in systemic advocacy. I mean, I think that this was a natural experiment where we saw that it was possible, and it was a, unqualified success. And so, speaking to your hospital leadership, speaking to community organizations that are involved in this advocacy. And then I think knowing the resources in the community is really important as well. So the Health Network for Uninsured Clients, hnuc.org, has a lot of resources. There's our website as well, if anybody would like to check it out. And this is just a QR code that takes you to our petition if you would like to sign that. So maybe I will stop here, and happy to take any questions. I'm also always happy for people to contact me. Like if you are a resident working somewhere, or if you're a staff somewhere and you have a question, I'm happy to put my email in the chat. And if you're working with somebody who's uninsured and you're sort of struggling with how to provide care to them, I might not have the answer, but I'm always happy to brainstorm.
Thanks so much, Michaela. That 7-point plan is a really great kind of guideline to follow for working on these very complex issues. Does anybody have any questions, comments?
Can I make one?
Yeah.
One, that was a great presentation. Love to see Michaela again. Michaela, as a PGY2 resident, I'm an old timer, was my resident, and I remember frequent discussions with her adamantly saying, nobody is illegal, and me saying, well, I'm not so sure, and we went back and forth. And so even then, I just wanted to add to advocacy and working with this population that sometimes direct contact with the people making the decisions about when they deport, when they don't, when they visit, when they don't, can be helpful. I had one case certainly where I called and got hold of a lady who was, the decision was almost to deport, and it was in a case of a woman from Mexico who'd been abused and all of that, and was illegally here and had kids, and I knew the kids and all that. But in talking to the lady who had to make the decision, she said, I can't really legally not deport her. She's gone through all the steps. And there was one more step, and I said, look, she's got a chance she might be married. She thinks she could be to a Canadian citizen, and we need a little more time. And sending her back will do this, and her kids and all. Can you do anything? And there was a long pause at the other end. Sweet lady. And she said to me, look, legally, I can't do anything, but I'm a single mom. I've got my own kids. I know some of the issues. I'm going to take her file. This isn't official, and I won't agree to say I said this, but I'm going to put her file at the bottom of the pile, and that'll give you some time. And we did. It gave us some time. I asked how long we had. She said probably around this. And the lady was able to get married and also apply. Long story short, got her citizenship. So advocacy can sometimes be at the personal level too. These are people also at the other end making difficult decisions. And when it becomes a real human being to them that you're obviously connected to, you have a lot more power than you think, just being a physician. It may not be right that we should have this, but this status, but we do, and people will listen to you. And in any case, this case, it worked out. And so I would also advocate at the very individual level of those people involved in making decisions. But nice to hear and see Michaela again.
Okay, thank you, Dennis. There's also one question Maggie answered in writing, but just wondering if we should answer now, Michaela, or maybe it's a question for the whole panel. Do you ever run into trouble with hospital or university media, public relations policies interfering with your work, which is, I think, a really important topic to address?
Yeah, I mean, I've thought about this a lot over the years. I have not run into trouble, but I'm also very careful not to affiliate myself unless I have that permission. So I think that, you know, I've a very I've done a lot of things that I think the hospital would not want itself affiliated with, but I've done them, you know, as a psychiatrist in Toronto, and that has never ever been a problem. But I think that a big part of it is working together and creating supportive environments where we can not be alone in doing this work. And I think that's why it's so wonderful to see the work that Maggie and Tilvier are doing, and that other residents are doing, and that, you know, people in all spaces in the community are doing, because it means that we're not doing this alone. And I think that makes it much less likely that we're going to be faced with any difficulty. And certainly if anybody's ever worried about getting into trouble at an institutional level, like, I'm happy to brainstorm and talk it through. Many people have done that for me over the years as well.
Okay, thanks so much. I think the question from Jacqueline Vincent can be moved into the panel, because it's a great question for everyone about how to maintain hope and optimism. That's something we would like all of our panelists to address. And maybe, Michaela, you can answer S. Hoffman's question in writing, because it's very specific about, you know, therapy and uninsured. So I want to thank you for the presentation, and I will turn over to Meng Xuan to introduce our panel now.